Did you vaccinate him?
Good morning, everyone. I'll be presenting on behalf of the Unit of Medicine 1. Presenting 53-year-old male plumber from Odisha who had no comorbidities, who's come to us with complaints of weakness in both the hands for the last 10 years. Started off in the left hand initially. He had history suggestive of distal weakness. He had difficulty in buttoning, mixing his food. Later on, developed difficulty in holding a pen. By the end of first 3 years, he had inability to make a complete fist on the left side, and the history was that the weakness gets worse on exposure to cold. He's developed similar weakness with similar distal weakness in the right hand also 1 year after the onset of the left hand, and that also progressed over the next 3 to 4 years. He also noticed thinning of his limbs over the first 3 to 4 years of illness, and his deficits have been static for the last 6 years. There is no history of noticing any spontaneous twitching movements, any history of sharp shooting pain in the upper limbs. No history of difficulty in reaching out for objects at a height, and there were no sensory symptoms that he complained of. There was no history of lower limb weakness, no recurrent falls, abnormal gait, scissoring, difficulty in climbing upstairs or holding his chappals, no history of difficulty in swallowing, leaking of water, diplopia, restricted vision, or reduced sensation on the face. His bladder and bowel habits were normal, and there was no prior history of road traffic accidents, any trauma to the upper limb, neck, or any history of neck pain. So coming to the examination, his pulse rate was 80 beats per minute, blood pressure was 120 by 80 millimeters of mercury, and respiratory rate was 20. There was no pallor, ictus, clubbing, cyanosis, lymphadenopathy, or pedal edema. There were no trophic ulcers, shiny skin, loss of hair, or reduced sweating noticed on his hands. The skin and nails appear normal on both the hands, and his teeth was normal. System examination wise, cardiac system examination revealed first and second heart sounds to be normal with no added sounds. Respiratory system showed normal vesicular breath sounds in all lung fields. Per abdomen was soft and liver and spleen was not palpable. There was no free fluid. Coming to the examination of the CNS, focusing on the upper limbs first, the left upper, he had equal bulk in both the arms and forearms. There was clawing noted in the left upper limb, which was more on the medial aspect than the lateral aspect, with flexion at the PIP joints. Wasting of thenar and hypothenar muscles on both the hands. Wasting of all the dorsal interossei, and first dorsal interossei wasting was more prominent. He had thinning of forearms, wrist drop on the left side, but not on the right side, and there were no fasciculations noted. This is a picture of his left hand. You can see that he has a clawing involving the first two fingers on the left hand, more prominent. And in the right hand also, he was noted to have a clawing. And you can also see the thenar and hypothenar prominences are not clear. Coming to the tone, he had normal tone at the shoulder and elbow. The wrist, the tone was reduced. He had power of 5 by 5 in shoulder flexion, extension, abduction, and adduction in both limbs. Elbow flexion and extension was 5 by 5, and wrist extension was 4 by 5. Wrist extension and flexion was 4 by 5 on both sides. Coming to the reflexes, he had intact 2+ reflexes on both sides, including the biceps, triceps, and the brachioradialis reflexes. Lower limb examination showed normal bulk tone and power of 5 by 5 across all joints in all range of movements. Cerebellum examination was normal. There was no C-spine tendon deformity or no spinal tenderness appreciated. So coming into the examination of the small muscles of the hand, this is the median nerve and the branches that it gives in the forearm. So it includes mainly branches to the pronator teres, flexor carpi radialis, palmaris longus, flexor digitorum superficialis, flexor pollicis longus, and FDP and pronator quadratus. So our patient had flexion at his wrist, which was weak, but there was no radial or ulnar deviation, probably because he had involvement of both the nerves. And he also had flexion at the PIP joint against resistance was very poor. Then coming into examination of the first two lumbricals, he had inability to flex at the MCP and extend at the PIP, which was causing the median claw. And coming to the three thenar muscles that are supplied by the median nerve, it's the opponens pollicis, the abductor pollicis, and the flexor pollicis brevis. These are just ways to how to demonstrate it. It's not the images from the patient. So flexor-pollicis, you fix the first MCP joint and ask the patient to flex the thumb, and you feel for the resistance. For opponent's pollicis, you ask them to oppose his fingers and feel the power in the thenar muscles. And for abductor pollicis, we do the pen test where you keep the pen above and ask the patient to lift his thumb and touch the pen. Our patient had weakness in all three muscles. He was not able to do the pen test, flexor pollicis and opponent's pollicis. Opponents, he was not able to fully oppose. Coming into the ulnar nerve examination, the branches given by the ulnar nerve in the forearm include medial half of the flexor digitorum profundus, the flexor carpi ulnaris, which again causes weakness in the flexion of the wrist. And coming to the hypothenar eminence muscles, and then there is the adductor pollicis, the third and fourth lumbricals, and the interossei. So muscles of the hypothenar eminence wise, he had difficulty in abducting his digiti minimi, and adductor pollicis we checked using the he had a positive Froment sign. He was not able to, he was flexing his DIP joint when trying to hold a card. Then we did the card test for a palmar interossei, which showed weakness on both sides. Left was worse, and he also had dorsal interossei weakness in that he could not abduct his fingers, and Egawa test for the dorsal interossei of the middle finger was also positive. Coming to the branches of the radial nerve, he had normal power in the triceps at the elbow with brachoradialis, and however he had weakness in extension of the wrist and in the fingers. So coming to the myotome examination, from the examination that I've described, we can see that he had difficulty in wrist flexion as well as finger abduction, helping us to localize it to C8 to T1 myotomes. He had normal triceps in that he could do a normal elbow extension. So syndrome that he presented to us with is bilateral asymmetric distal LMN weakness in both the upper limbs, left more than right, with C8 and T1 myotomes being affected with no sensory involvement and reflexes being preserved. So our localization was to three regions. One, anterior hornsel was considered. Factors for an anterior hornsel involvement in him was a pure motor neuropathy and the element findings that we had, but we were not able to see any fasciculations. Second one was the nerve root of C8T1, and factors for was intrinsic muscle and wrist extension, which was affected, and normal triceps and brachioradialis. However, he did not have any history suggestive of radicular pain. Third one we considered was a pure motor neuropathy also. So among the anterior hornsel diseases with distal upper limb involvement, we have monomelic amyotrophy like Hirayama's disease and O'Sullivan-McLeod syndrome. And root-related causes, impingement of C8T1 by spondylolisthesis, tumors like ependymoma, meningioma, or a metastatic lesion, and pure motor neuropathy like multifocal motor neuropathy with conduction block was also considered. It was considered lower down on the list. So we went ahead and did EMG and CV for the patient, and it showed motor neuropathy involving both the upper limbs with no response to stimulation in both the ulnar nerves and decreased amplitude with normal latency in all the upper limb nerves. We did an MRI of the cervical spine. Here you can see that you can see a linear hyperintensity extending in the C8T1 region and also slightly above it. And in the in this view, in T2 weighted image inflection, you can see the what is classically called the owl's eye sign. You can this is the spinal cord, and the bright white spots in the middle are the enhancement of the anterior hornsels, and you can see a split in the dura, which is causing this hypodensity. So the owl's eye sign is also called the snake's eye sign. It's a bilaterally symmetric circular to ovoid foci of high T2 weighted signals in the anterior hornsels of the spinal cord. This represents increased metabolic activity and reduced collateral supply of the anterior hornsels. It's seen in cases of anterior spinal artery ischemia, chronic compressive myelopathy like Hirayama, and sometimes in ALS and NMO also. So coming on to just a little bit about Hirayama disease, it is a degenerative disease that progresses over 1 to 5 years and then tends to plateau. The pathogenesis, there have been three pathogenesis that have been explained for the development of the symptoms. First one is the tight dural canal theory inflection, wherein it is suggested that there is increased laxity of the dura mater from its superior anchors, which causes forward movement of the cord during cervical flexion. This causes a subclinical cervical trauma and microischemia to the anterior horn cells of the spinal cord, which finally leads to myelopathy and degeneration. The second pathogenic mechanism that has been explained is an increased intramedullary pressure during neck flexion that causes stagnation of the posterior epidural venous plexus and the plexus causing a cord compression. Loss of dorsal dural attachment from the pedicle due to immunological abnormalities of the dura and the posterior ligaments have also been hypothesized. Management of Hirayamas, most of them suggest clinical observation only because it's a benign disease and it doesn't progress to a systemic motor neuron disease. And the recovery chances are much less in Hirayama's disease. A few people have also tried cervical collar to prevent the recurrent trauma when the neck flexion happens. And surgical decompression with fusion has also been described in literature. So our patient, he was from Odisha, and after that train wreck, they had to go back immediately. So his assessment is not fully complete yet. We have got an HLRS consult to help him with some physiotherapy that would improve the muscle power in his hand. He is a plumber, and he's able to do the activities of daily living as well as his work-related things with his.
Two questions. One, he has a 10-year-old disease, no? Why did he come now? The progression of the disease?
He came for physiotherapy mostly, ma'am.
Second thing, can you go to a list of differentials? He's got a pure motor element symmetrical
asymmetrical
upper limb involvement. Would we consider root for a no sensory involvement is it's a pure motor, no? So I think
lesser.
When you say root, you are implying both, right? Sensory plus this one. And the third pure motor, you're thinking of a multiplex modality.
Yeah.
Any comments or questions?
This is the age of onset of the symptoms. They seem to be slightly older
elderly.
Than typical.
Yes, sir.
So what was the age of onset of this?
32 years, sir.
His age of onset was after the growth.
Yes.
Seems to be very atypical. The weakness, usually the damage happens as you are growing. How can somebody's onset of disease start at 30 years of age? And then we say that it plateaued because the growth is completed. That's the concept in Hirayamas.
Yes.
So the growth is completed, so there is no further stretching. Hence, the disease doesn't progress and it plateaus. Here we are having a fully adult male whose spinal canal cord, everything is fully grown, stretched, then develops the symptom, progresses for another 6 to 7 years, and then remains static. Seems to be a little atypical. The age is not fully in bodies.
Why do you say that you are considering neuropathy low order? You specifically mentioned that you consider it as low order. I were to run the list of questions, I would put this is the first definition of confident mononeuritis, which is of pure motor type as a first definition, because that explains all the symptoms in a more sustainable fashion than anterior onset.
But only thing that was against was he had predominantly only upper limb involvement. There's no nerves in the lower limb which was affected at all. So that was one reason.
I want to ask you, I'm not sure about this, but the Hirayama disease usually have hypertonia or
hypo.
My understanding is that nobody really knows what is the pathophysiology of Gilliamas has been classified into which group of disorders called motor neuron diseases because clinically there is both human and animal science, and the human science is usually hyper. I do not know. I that was my understanding. That's what I know.
So finally, where have you localized the lesion to?
The anterior horn cell, sir.
Anterior muscle, but you said no fasciculation, and your EMG also is not consistent with the EMG and CT sample.
For the needling findings that are not mentioned, the myography.
Okay, I'll double check.
Is what will tell us the localization is actually your
Anterior.
horn cell.
Needling was showing chronic degenerative changes in C7, C8, T1. But that was, we thought it was the effect of the response to the damage. So that's why we didn't put it up. It was showing giants and absent conductions and all that. So there were giants in the ulnar nerve, suggestive of regenerative process, like nerve regeneration trying to happen.
We're focusing on the muscle. Let's not focus on the NCS here.
Okay.
Focus on the muscle, on the needling. You need to get something like an insertional activity, fibrillations, fasciculations on your myography to say that the localization is probably your anterior horn cell. 1. 2. When your clinical localization comes to 2 myotome, something like C8T1, don't evoke root without a root symbol. Just because you get C8T1, it doesn't mean I will evoke my root. What Amit was telling you, first clinical differential should have been pure motor nerve. Localization goes to pure motor nerve. So the motor nerve is your first clinical localization. Yes, anterior horn cell will become your second differential. Please don't evoke root here as a differential. You don't have any root symptoms. There's no reason for you to evoke root just because you got two statements from root. And needling is what? Findings of the needling is what is going to confirm. And the Kirayama is phenotypically similar to ALS. It is just that it is a segmental ALS. So classically, you will get human plus LMNHs. You will get hyperreflexia with wasting, with facets, at least in the patients I've seen.
There are elements, there is significant wasting. I don't want facets. I'm not worried about the absence of facets. If you want to get the element, there are no. Again, disclaimer, this is what I
Pure motor neuropathy. Which nerve is affected here? Here the
median,
weakness
ulnar,
involving
and
muscles innervated by medial nerve, ulnar nerve,
and
radial
radial.
nerve. So the most likely localization is
Anterior
horn
horn
cell.
cell, yes.
Again, what same question which Anuka asked. So his symptoms have been there for 10 years. He's been static for 6 years. So why has he come now?
He's come mainly for physiotherapy only, sir, to see if he can improve the power in his hand.
Why now?
How are you explaining the modern?
Hmm?
How are you explaining the findings of modern neuropathy tendency?
The
No response. Is that
The
possible with the
Join? No. Yeah. Okay. So the relation that no responses.
we understand that on the MRI you will find features that are consistent and many of the clinical features are consistent. Just trying to see if there is something.
The only thing I find strongly atypical is the age.
age.
Progression seems to It's a rare disease, we all not seen.
Bilateral involvement is common. It's basically
Monomelic. But they can have bilateral.
Right, the first discussion, Urayama was some juvenile population. We are always involved.
I would like to thank all the presenters and for the best clinical syndrome description and a concise discussion. I would like to give the present to Tefila.